Hi, my name is Randy Beckett. I'm a psychiatric nurse practitioner, and I'm here talking to you today about resident on resident aggression. This is the part 2 video of this series that we're doing on this very, very important and challenging issue. In the first video, we talked about some contributing factors of the resident who may engage in resident on resident aggression. We talked about that the research says male, although we know that females are perfectly capable of resident-on-resident aggression. Affective disorders like depression, anxiety, other mental illness disorder like schizophrenia, bipolar disorder, delusions, hallucinations, cognitive impairment, a history of substance abuse, traumatic brain injury, dementia, cognitive impairment with more mobility and independence, perhaps being able to walk with a walker independently or self-propel in a wheelchair. So these are some of the, and of course, a prior history of aggression is also important. So these are some of the contributing factors. Now we're going to look at contributing factors in the environment. Well, one thing that is difficult today in this post-COVID world is staffing levels. And of course, with a lower staffing ratio, it's more difficult to redirect somebody who walks into another resident's room where there could be aggressive behavior happen, or to a resident who kind of gets in the space or the face of another resident, or who is going up to touch other residents. This, even in a locked unit with a lower staffing ratio, this is obviously a lot more difficult to manage. The other thing are, busy and overcrowded spaces. So if there's a high census in a particular area, hallway, unit, that creates less space, more tension, more stress. You can feel it when you walk in, that there's kind of a vibe of increased tension. And it doesn't allow for people to move freely. They tend to run into each other and get in each other's space, which can lead to verbal or physical aggression, or lack of privacy. Where they just don't have the space that they need to handle their daily needs. One thing that I've noticed, and I've had several nursing homes which have stopped using alarms, chair alarms, bed alarms, where people stand up next to the bed, because these things really cause agitation and increased anxiety. In the nursing homes that I've worked with who have reduced dramatically or eliminated the use of these alarms have noticed a decrease in aggression, anxiety, agitation in their residents. Any additional noise, like a loud TV that's on all the time, or overhead announcements or alarms going off. You and I know that just in our own lives, that when there's this kind of constant thing going on or there's noise, we get more agitated. And that can also lead to aggression in residents. If it's too hot or too cold, or if you happen to be in a place where it's winter, when it's winter, and people can't go outside and get some fresh air, that confinement can lead itself to increase aggression. The other thing is when residents have a hard time finding their way around, where the space is kind of confusing, or dead-end hallways where there's a door down there that they just want to go out of. That can lead to increased agitation and aggression. A couple of characteristics of people that excuse me, have more likelihood would be hearing or vision loss. They can't see as well. They can't hear. They may not understand what somebody else is saying or another resident is saying, or can't see the other resident or run into another resident who has cognitive impairment or a mental illness, and there can be a clash there. Or, just not being able to hear and communicate also is very frustrating for people, and especially people with mental illness or with cognitive impairment can lead to increased agitation and aggression. Pain, even musculoskeletal pain like arthritis pain, doesn't have to be a malignant pain, but pain like a hip pain or shoulder pain or neck pain or headaches. I mean, I know when I get a headache or I'm in pain, I tend to be more irritable. And this obviously would be true in our residents. And so I've seen just like a shoulder ache and put a lidocaine patch on it, recognize what it is, using something topical or, Bengay or something. Lidocaine patches tend to last a little bit longer, so that's why I mentioned that. That can decrease people's level of agitation and propensity for aggression. Of course, incontinence is also, it can be embarrassing, and also it can be agitating and irritating to a resident, can lead to aggression. We all know the classic change in mood or behavior or delirium or delusions or increased agitation associated with urinary tract infections. And sometimes this change in mood or affect or delirium may be the only symptom that we see. And I know we have criteria on when to do a urinalysis, but often in my experience that just the change in mood is because the patient may not be able to tell you that, oh, my abdomen hurts, or they may not be able to tell you if they're incontinent that I feel like I have to go to the bathroom or I have burning when I urinate. So the only symptom left may be delirium, and this needs to be evaluated and treated. Boredom, people get bored, they get in trouble. Idle hands, and they can become very aggressive when bored because they get irritable, and also tired if they're not sleeping well at night, or maybe because of pain they're not sleeping well, or they're just fatigued. There's an organic reason for their pain. Maybe they have a vitamin deficiency, maybe their thyroid hormone is low, or maybe they're malnourished for some reason, but fatigue can lend itself to that, as well as frustration. Repetitive speech by others, where people ask the same questions over and over and over again, or say the same thing. So somebody who is very cognitively impaired might be asking the same question as someone who is cognitively impaired enough to not understand that this person is cognitively impaired, but all they do is just hear this repeated questioning or saying the same thing over and over again, or making nonsense syllables, and that can lead to frustration on the other person's part and can lead to verbal or physical aggression. Of course, we talked about going in bedrooms, people wandering in bedrooms. Rooms that have shared bathrooms, I have seen, have been a tremendous trigger for verbal aggression and physical aggression, where they pound on the door, or somebody leaves the bathroom dirty, or they won't get out of the bathroom, or just a cascade of reasons how bathrooms can cause problems. Unfortunately, racial, ethnic slurs or comments can trigger. I have seen this in different facilities, and it can be a real problem and a very quick trigger. So these are things to look out for and are like early warning signs of a potential for resident on resident aggression. There are many more, and we can't list them all, but you get the idea that this is something to be aware of, along with the residents' personal backgrounds, but contributing factors and triggers for resident on resident aggression. These are things to be very aware of, because you can see in advance, and especially with experience with people, and we really get to know people very well. And we know when a situation arises where this could be a possible trigger for a incident, a reportable incident of verbal or physical aggression, or actually, sexually inappropriate behavior, wandering in another person's room and touching them inappropriately. So we have to really be vigilant about these possible triggers, and that will help diminish recognizing the characteristics of people who often engage in resident on resident aggression, but also the situations that lend itself to resident on resident aggression are very important for us to keep in the back of our mind, and have this awareness of our environment to help prevent, because it's a lot easier to prevent than it is to intervene and report. Thank you very much. That's the end of this segment. I'm Randy Beckett.